Good morning, everyone, and welcome to another Asia Novel Seminar organised by the Arthroplasty Society in Asia and its official journal, Arthroplasty. The ANS program is designed to establish a professional forum and a network that arthroplasty surgeons from all over the world can be connected through to share their personal ideas, clinical experiences, and also cutting-edge technologies and techniques. My name's Andrew Kermis. I'm from Adelaide in South Australia. I'm affiliated with the University of Adelaide and Flinders University, and I'll be co-moderating today's seminar. I'm also the guest editor for an upcoming special issue of the journal Arthroplasty, focusing on both robotics and artificial intelligence advances in joint replacement surgery. So today we are presenting episode number 2 of the 4th season of the ANS, which has been co-branded with the Hong Kong Orthopaedic Association. On behalf of Asia, I am honoured to have 3 eminent special guest speakers joining us today. Dr. Chun Hoi Yan from the Gleneagles Hospital in Hong Kong, Dr. Young Soo Chen from Shanghai 6th People's Hospital, and Dr. Henry Fu from the Queen Mary Hospital and the University of Hong Kong. Welcome, everybody.
Thank you.
Hello. Hi, I'm Dr. Henry Fu, and I'm happy to be the co-moderator for this seminar with Professor Kermis. In this episode, we will focus on some innovative robotic-assisted surgery advances for complex primary total knee arthroplasty. We will discuss what is a better way to keep the best alignment and balance, and discuss how to treat major bone loss and the stiff knee. Today, Dr. Yan and Dr. Chen will present their expertise using robotic arm-assisted technology. Professor Kermis and I will introduce how we treat major bone loss and stiff knee with robotic-assisted techniques. There will also be a discussion part at the end. It is also welcome to have your questions and that we can discuss after the seminar. Okay, so now let's get started. The first speaker is Dr. Chun Hoi Yan from Gleneagles Hospital, Hong Kong. I'm happy to introduce him to the Asia audience. He is the president of the Hong Kong Orthopaedic Association and the director of Joint Replacement Center in his hospital. He specializes in hip and knee replacement surgery as well as orthopedic trauma. He's also the section editor-in-chief of the Advanced Technique section of Arthroplasty. He will talk about the topic with Mako total knee arthroplasty dynamic knee balance. Dr. Yan, please.
Thank you very much, Harry, for your kind introduction. Good morning, everyone. I'm Dr. Yan Chun Hoi, and the topic of my presentation is Mako total knee replacement with dynamic knee balance. So here is my disclosure. I think there are 2 questions we need to ask ourselves before we do total knee replacement. First, whether everybody has a neutral mechanical alignment to start with, and why do we want to achieve a mechanical alignment within 3 degrees of varus valgus after total knee replacement. I think in the past, a lot of people believed in neutral mechanical alignment after knee replacement. It's because many papers published emphasized on the importance of this alignment in the longevity of the implants. But I think in 2012, Bellum published this milestone paper. He discovered actually a lot of people had constitutional varus. I think this is very significant in number, especially in Asian patients, because when we operate on our patients, we will always find people with constitutional varus. And this constitutional varus created special challenges in doing total knee replacement. Is because we have to release the short MCL if we chase after a neutral mechanical alignment. And excessive release of the medial collateral ligament will result in pain and stiffness after the operation. And I think this is another very important paper published in 2010 by the Mayo Group. They studied the effect of the lower alignment and on the survivorship of the implants. So they studied almost 400 cases. Mean follow-up was 15 years. And they grouped them into the post-op alignment, the well-aligned group, and the outlier group. and used 3 degrees plus minus as the definition. So you can see the result. They used any revision and also aseptal loosening as the endpoints. And the Kaplan-Meier survivorship curve showed us that actually there was no difference between the well-aligned group and also the outlier group. And 1 year later, this is another paper published by the UK group, also studying more than 450 PCA total knee replacement, mean follow-up almost at 10 years. Again, they did not find any difference between the mal-aligned group and the well-aligned group in terms of the survivorship. So now I think we have more acceptable total knee replacement alignment targets, whether you want to use the conventional mechanical alignment or even kinematic alignment. I think that's very controversial and also very popular nowadays. Some people propose the inverse kinematic alignment, whether when you cut the tibia first, not the femur first, and use the tibia to balance the femoral component. Some people proposed restricted kinematic alignment, so you have you need some restriction of boundaries in putting on the implants. And I think most of people now, we focus on the functional alignment or patient-specific alignment. So usually we should put the component within 5 degrees, varus and valgus. And overall, the lower limb alignment, we have to control them in between 3 degrees valgus to 6 degrees of varus. So now I think we have more and more alignment targets. We do not only need to chase after a 0 degree, and we have to focus on the gap balancing, which is more important. So the robotic arm-assisted total knee replacement help us with the dynamic balancing of the knee. I think we used to use a mid-resection balance, which is quite popular when we do a manual total knee replacement. So first we remove the osteophytes, and then we cut the bone according to the pre-op plan. We check our extension gap and recut the extension gap, or maybe we need to release some of soft tissue, and then we have to balance again in a flexion gap to match the extension gap. So we need to achieve a rectangular gap in flexion extension. But with robotic assisted total knee replacement, we can use the concept of a pre-resection balance. So remove the osteophytes, tense up the medial collateral ligament in both extension and flexion. We adjust our bone cut plan, plus minus soft tissue release, and then we cut the bone, and then we check the gap. So the beauty of the pre-resection balance is that we know what the gaps will be before we cut the bone. So how do we do this? In extension, I think after removal of the osteophytes, the knee will be put in extension. So for a varus knee, the medial collateral ligament is tensed up either by putting in the medial spacer puddle, or we can apply valgus stress. Myself, I think putting the valgus stress is probably easier. And we have to note the lower limb alignment, whether there's flexing contracture, and what is the medial and lateral gaps. So for this, for example, after the release, we can see that now the lower limb varus is about 3 degrees. The flexing contracture is about 9 degrees. And then we note the medial lateral gap. Usually the medial gap will be tighter in a varus knee. And for the lower limb alignment, we do not have to chase after 0 degrees. It does not need to be neutral every single time. Just need to be acceptable. So in varus knee, I think we can accept less than 5 to 6 degrees of varus overall limb alignment after the surgery. We do pie crust the MCL if the residual varus is more than 6 degrees. In valgus knee, we can accept valgus up to 2 to 3 degrees. We routinely release the posterolateral capsule plus minus the iliotibial band. For very severe valgus knee, I think we now can use the Mako 2.0, which allow us to do mid-resection balance, because I think the pre-resection balance may not be able to handle the severe valgus knee, where you cannot release the posterolateral capsule. But with Mako 2.0, we can do that. And concerning the flexion contracture, if the flexion contracture is less than 10 degrees, we can overcome this by adding extra bone cut from a distal femoral cut. So when we add 1 mm distal cut, that would correct about 5 degrees of flexion contracture. But if the flexion contracture is more severe than 10 degrees, then we have to be careful. We need to remove the posterior femoral condyle osteophytes. We need to do a thorough posterior capsular release. Sometimes we may even need to do a provisional posterior femoral condyle cut to access to the posterior side of the knee, but we have to be very careful when we do dynamic balancing and flexion, because now we lose our anatomical landmarks. And for the medial and lateral gaps, we usually need to assess in 10 degrees of flexion. We do not want to assess the medial lateral gap in 0 degrees of flexion, because we want to eliminate the effect of posterior tightness. So for varus knee, in extension, usually the medial gap is tighter than the lateral side. So we can either overcome this by putting a varus tibial cut and then slight internal rotation of the femur to achieve a rectangular flexion gap. We can also put the varus on the femoral side, or in very severe cases, we can put varus on both femoral and tibial side. And we have also need to be careful in choosing the anchor point at the medial, middle, or the lateral side, depending on the thickness of the polyethylene liner and also the degrees of flexion contracture. So for example, let's use this case. You can see that now the lower limb varus is only 3 degrees, and the flexion contracture is 0 degrees. So we can accept this 3 degrees of varus. We don't have to chase after 0 degrees. And we just need to balance the medial and lateral gap by changing the bone cut. And for this side, because I think the lateral side is 21 millimeters, it's a bit tighter. It's a bit loose, so we can close up the lateral side a little bit. So we can anchor the femoral point bone cut at the medial side, and then put more varus on the femoral component and cut less bone from the distal lateral femoral component. If that's another case, see, we have 3 degrees, but the flexion contracture is 9 degrees. So this patient has severe flexion contracture, and we need to have a bigger extension gap. So in this situation, we can anchor on the lateral side and put the femoral component in varus, and then we can cut more bone from the distal medial femoral component. So increase the extension gap to both 21 millimeters. In that sense, we can get a balanced extension gap and also overcome the flexion contracture. And then after the extension gap, we comes to the flexion gap. So after removal of the osteophytes, we put a knee in a 90 degrees of flexion. For a varus knee, the MCL is tensed up by the medial spacer pedal. And also, we now used to put pedal on the lateral side as well. So we tense up both sides to see the actual flexion gap. And for the medial and lateral gap, we note the width. So that's the component thickness, and also want to achieve a rectangular balanced gap. So for example, in this case, we can see that the patient has tight flexion gap, medial side 13 millimeters, lateral side is 15 millimeters. So for this case, I think the flexion gap is too tight. If it's too tight by 1 to 2 millimeters, we can overcome this by increased tibial slope or anteriorize the femoral component. If the flexion gap is tight by 3 to 4 millimeters, we may consider downsize the femoral component plus anteriorize the femoral component. When there is a flexion gap imbalance, for example, the medial side is tighter than lateral side, we can increase the external rotation of the femoral component. Whether we want to anchor this on the medial side, middle, or the lateral side, it depends on the width. So I think this is the case. Now the external rotation of the femoral component is 4 degrees. We can actually increase the external rotation to 7 degrees and also anteriorize the femoral component. And this, you can see that allow us to achieve a more reasonable and a flexion gap to 18 millimeters. And this is a case example. We had bilateral osteoarthritis of knee. On the right knee, the patient has varus alignment. There's less FFD, and there's a limited flexion. So you can see that this is a before release. The patient has varus of 14 degrees, loose extension gap, and quite tight medial gap. This is after release. You can see still the medial side, the gap is 18 millimeters, lateral side is 22 millimeters. So in the pre-plan, we put femur in 2 degrees of valgus and a tibia in 2 degrees of varus, and aim at 0 degrees of a mechanical alignment. And still, the lower limb varus is about 5 degrees. So can we accept this 5 degrees, or do we need to do a more medial collateral ligament release? So I think we can change the bone cut from 2 degrees of valgus on the femoral side to 1 degree of varus. So we cut less bone laterally, and we tighten up the lateral gap. So now we can achieve a rectangular extension gap. Now both sides 90 millimeters, and accept this constitutional varus. And the flexion gap is 15 millimeters on both sides, which is quite tight. So we can downsize the femur from size 4 to size 3. So we cut more posterior condylar bone. So at that sense, we can achieve a better flexion gap to 18 millimeters. And this side, we can also consider increase the tibial slope from 3 degrees to 4 degrees. You can open up the flexion gap by 1 millimeter more. So in that sense, we can achieve a 90-90-90-90 flexion extension gap. And on the left knee, the patient had more varus deformity, more flexion contracture, but the patient had better flexion on this side. So we can see that there's an imbalanced medial lateral extension gap, and the lower limb varus was 18 degrees of varus before release. And after release, you can see that we can correct the lower limb alignment to 6 degrees of varus. But we have to note that the alignment we accept is about 5 degrees, maybe our boundary. So this is 1 degree more. So what should we do? I think we can release a bit more, or we can try to see after correct the flexion contracture, what we can do. So this knee has 12 degrees of flexion contracture, which is quite significant. So like the right knee, we changed the femoral bone cut from 2 degrees of valgus to 1 degree of varus. So we open up the medial side. So now we can see that the extension gap is 21 millimeters on both sides. Hopefully we can achieve better knee extension after this. And unlike the right knee, we cut more bone medially rather than less bone laterally. So because the patient has more significant flexion contracture. And the extension gap was increased by 2 millimeters to correct the flexion contracture. And on the femoral side, the flexion gap was not too tight. It's 16-17. So we keep size 4. We did not undersize the femoral component. And we widen the flexion gap while anteriorize the femur and also increase the tibial slope. So this can help us achieve a better flexion gap without downsizing the femur. So that's our final plan. So now we can achieve 19 degrees of, 90 millimeter on both sides in the flexion gap. So here's the X-ray. So after the knee replacement, you can see that the implant position are quite nice. We can achieve balanced flexion extension gap. So regarding the boundaries, I think this is a very good paper published by the Australian surgeons. For this individualized functional knee alignment, we need to have some boundaries. And this is the boundary proposed by the authors. Because of the time, I cannot go into the details, but I think I already mentioned in the talk. And in terms of the joint line obliquity, I think this is another very important point for us to consider when we do a robotic total knee replacement. For this study, they had a prospective study of 300 functional alignment total knee replacement using Mako. They did 135 with a MA plan and 165 using the kinematic alignment plan. And they studied these two groups with a minimum 2 years outcome between the FA, the mechanical group, and the kinematic group. They used the CPAC classification to classify the phenotypes, and they found actually for the kinematic total knee replacement group, they reported higher forgotten joint score and also greater range of motion. And the patient who had constitutional varus actually reported the greatest improvement with the kinematic technique. So we have to bear in mind, if you see a patient with constitutional varus and big joint line obliquity, then functional alignment maybe is the answer. So with robotic arm total knee replacement, now we can achieve very good dynamic balance, which gives the surgeon a balanced gap during the operation, and we can achieve functional alignment after the surgery. Thank you very much for your attention.
Well, thank you very much, Dr. Yan. It's a fantastic talk and a very good example of understanding the influence of both bony control and soft tissue releases. So I've learnt much from that too. So let's move on now to our second presentation. It is my honour and pleasure to introduce our next speaker, Dr. Young-Soo Chen from Shanghai 6th People's Hospital. Dr. Chen is the Deputy Director of the Joint Centre in his facility. He's currently sits on the editorial board of Arthroplasty, and we're also co-editors together as guests for an upcoming Arthroplasty special edition. So I'm looking forward very much to hearing Dr. Chen's talk describing his short-term results using the Mako robot and a functional alignment philosophy. Thank you, Dr. Chen.
Thanks, Dr. Kermis. I'm Yunsu Chen from Shanghai No. 6 Hospital. Today, I want to report our short-term result using the functional alignment in Mako-assisted total knee arthroplasty. As we know, we did the first Mako total knee arthroplasty in May 2021, and till now, we have finished more than 700 Mako total knee arthroplasties in our hospitals. We know, just as the Professor Yan talked about, that the total knee arthroplasty alignment is also evolving, not revolution, but evolving. We have different alignment techniques. Usually, classic alignment is the mechanical alignment, but till now we have different alignment. We can use kinematic alignment. We can use reverse kinematic alignment, which do the tibial first. And we also with the restricted kinematic alignment, which were the various valgus is limited into 3 degrees. When we do the Mako, we begin use the functional alignment in our institute. What is the functional alignment? That means the surgeon simply remove the osteophytes, just as the Professor Yan talked about during the operation, to adjust the alignment to about within the 5 degrees. Then we fine tune the implant position. Usually we do not release the soft tissues. Then we can achieve the balanced gap and soft tissue tension. So still, we remain the patient's natural lower limb alignment, usually within 5 degrees of HKA. After that, we precisely do the osteotomy. According to the BJJ Ferris-Headed, they define the functional alignment. When we do the functional alignment, begin with the MA. This is the limited of the adjusted degree of these coronal and sagittal degrees. And when we do the RKA, from the RKA, the functional alignment is within 6 degrees. So the question is, does functional alignment works better than MA with Mako assisted total knee arthroplasty? So we want to answer this question. In our institute, we did the single center prospective randomized control study. About 100 patients were involved in our institute, and we classified into 2 degrees, 2 groups, which is one control groups where you use the mechanical alignment, and with this another research group is in functional alignment. We also do the hierarchical analysis with very severe varus and not severe varus, and with very obesity patient and not obesity patient. So this is the MA groups. When we do the MA technique, we keep the patient's alignment within 0 degrees. We do not change the coronal alignment of the lower limb. So we keep it 0 degrees. The plan is 0 degrees. Even though this is very difficult, various patient, we still do not do the adjust the prosthesis degrees. We only do the release, just as a classical technique. We also can do the very balanced gap. The plan varus and the lower limb varus is 0 degrees. And we also do the very balanced gap, but we do a lot of soft tissue release. When we use the functional alignment technique, we can, this is also very severe varus patient. Even though we cannot cut the tibial, medial tibial plate with a very about 3 millimeters bone loss. So in this groups, we adjusted the prosthesis degrees. We keep the varus in the tibia and the varus in the femur. We can see that with the planned varus at about 4 degrees, and we also can achieve a very great balanced knee. This is a very well-balanced knee in the extension and also in the flexion. So after the adjustment of the prosthesis position, we can have a very good balanced knee. So we evaluate these two groups, involve the leg alignment and operation parameters. We also evaluate the patient outcome. So first, we evaluate the operation time. We can see in the functional alignment groups, we can have reduced about 5.5 minute compared to the mechanical alignment. And in the subgroups with very severe varus before surgery, the functional alignment group have a mean reduction of about 10 minutes compared with the mechanical alignment. And in the obesity subgroups, the average reduction of the time in functional alignment is about 8.7 millimeters compared to the mechanical alignment groups. How about the alignment? We can see it in the mechanical alignment groups, the result is about 0 degrees. And in the functional alignment, the result, the average angle is about 3 degrees of varus. This is very, very interesting thing. When we use the functional alignment, most patients will focus on we will keep the very normal constitutional varus. So this is the Asian patients. How about the soft tissue release? The functional alignment groups, we do the less soft tissue release, and the mechanical alignment, we do about 50% patient will do the very severe, more release compared to the functional alignment. We also compare the early function result of functional alignment and mechanical alignment groups. The first is the pain. We can see the functional alignment groups, they have very lower pain in the active pain, in the pain on stairs at the 3 and 6 months after surgery. And the knee joint motion, the range of motion was similar between these two groups, and difference was no statistically significant. We also compared the early function result of these two groups. The satisfaction, there was no satisfaction difference at any time. The Coons, there was no statistical difference in total score at any time, but at 6 months after surgery, the functional tests was significantly better than MA techniques in Coon pain, daily activity, ability, and quality of life scores. There was no significant difference between Coon symptoms and Coon sports and recreations. How about the forgotten joint score 12? In 6 months, forgotten joint score in FA groups was superior than MA groups. We also did a comparison of these very hierarchical analysis with severe varus and non-severe varus. There's no statistical difference between these two groups because of the volume of the patient is too small. But when we compare the obesity of these two groups, there is significant difference between these two groups, which means that the functional alignment groups is much better than mechanical alignment when we compare the Coons 3 months and 6 months. But also the forgotten joint score is different. So the summary of our study, at 6 months of follow-up, functional alignment arthroplasty was significantly better than mechanical alignment when we used the robotic total knee arthroplasty in terms of functional improvement and pain reduction. And the obese patient benefit more from functional alignment. The functional alignment techniques are associated with less soft tissue release, more physiological alignment, and shorter operating time. The more serious obesity and various deformity, the more obvious these two group difference. So our conclusion is when we use the Mako robotic arthroplasty, total knee arthroplasty, the functional alignment or personalized alignment is a reasonable technique. In addition to the classical MAAA, there are a variety of total knee arthroplasty alignment method waiting for inspection. Functional alignment is widely used in Mako-assisted total knee in clinical practice, especially in our institute. It can restore the natural lower limb alignment. It can lead less soft tissue release and less post-operative pain and faster functional recovery. The long-term clinical results are worthy of expectation. Thank you for your attention.
Fantastic. Well, thank you both, Dr. Chen and Dr. Yan, for a pair of wonderful and very informative presentations, and very interesting to see some different expertise and interpretation of some of those alignment philosophies and how they've made good outcomes for your patients, which is very impressive. So now we'll pause the live talks and we'll move into the first of our interactive panel discussions. And I saw there were a couple of questions already coming through on the chat, which is fantastic. And I'm sure a couple of other speakers had questions. So did we have any questions for Dr. Chen or Dr. Yan to start us off?
Dr. Yan, I have a question for you. Can you hear me?
Yes. Yeah, of course.
In your presentation, I see that when we use the Mako, we can see a lot of flexion contracture in the inspection. But in our clinical experience, we cannot do the flexion according to this, according to the Mako shows. Usually we keep about 3 or 4 degrees of flexion. What's your opinion?
You mean in your practice, you actually want to keep 3 to 4 degrees of flexion contracture after Mako knee?
Yeah.
That's your practice. Do you have any theory or why do you want to keep?
Actually, there's not when we do the Mako, if we put the knee in zero flexion, we see that usually it is hyperextended.
I see. All right. Yeah, I get. I understand what you say. In my practice, actually, I do not deliberately chase after 0 degrees, but I think less than 3 degrees I accept. More than 5 degrees I don't. So I think Mako just a tool, and the surgeon, you should have the feeling after you put the tri-implant in. You assess the laxity in flexion, in extension, and the stability of the knee. I think you still get a feeling how stable the knee is. I think the surgeon's experience and feeling, I think it's quite important. Still, the robot is just a tool, give you some feedback, but I think your assessment with your hand is very important. So I think, I would accept less than 5 degrees of flexion contracture. I think that's easily can be, corrected after post-op rehabilitation. I think there's a question on the chat box. Someone asked in my presentation why in one case I put 21 millimeter in the extension gap and then 19 millimeter in the flexion gap. I think it's because maybe I rushed through my slides because of limited time. In that case, I think the patient had more than 10 degrees of flexion contracture to start with. So as a result, I deliberately put more distal femoral cut, making the extension gap 2 millimeters wider. So that's deliberate, and because I want to correct the flexion contracture. But if after initial release there's no more flexion contracture, then definitely we should achieve equal flexion and extension gaps.
So I see from chat box that there is a question from Lincoln Leo from SGH to Professor Chan, talking about his impressive results in the FA group. And what are your thoughts on the CPAC classification, selecting CPAC 1, 2, 4 to undergo functional alignment TKA for optimal results, meaning the apex distal type of CPAC classification, where there's some joint line obliquity. So, Professor Chan, how would you deal with this scenario?
Yes, that's a very good question. We usually see that there's a CPAC classification of the lower limb, and especially they classify the joint line obliquity. In these very different CPAC classification patients, we also do the functional alignment about in these groups. Just do not because the functional alignment when we adjust the tibial joint line, it is restricted within 3 degrees. So this is also we can get very optimal results.
All right, my turn for a question. Professor Yan, if you would. I get the sense that we all deal with slightly different populations of patients and the deformities that we see in different practices, let alone different regions. I got the sense both of you gentlemen deal with quite significant coronal plane deformities often. You mentioned in your slides that you use a 5 or 6 degree cutoff for your varus knees before soft tissue releases. You mentioned pie crusting. Could you give us an idea what proportion of your patients would exceed that 5 or 6 degree cutoff and routinely require pie crusting?
Right. I would say maybe less than 5% of the patients I need to do pie crusting. So that's a rough estimation, 1 in 20, I think. When I look at the patient, the varus deformity is very significant, and there's no wide opening up of the lateral collateral ligament, then I know that patient must start with a very severe constitutional varus. So yes, less than 5%.
Thank you. And Professor Chen, a question for yourself, if you would as well. One of the comments or one of the questions that comes up often in robotic-assisted total knee arthroplasty forums is about the inability of the robot to manage the soft tissue envelope prior to doing some of those posterior releases. And different systems have proposed different ways of managing that, whether the releases are done, when the assessment is done after the distal femoral cut. You mentioned in your talk, both of you, about the role of posterior capsule, about the role of significant osteophytes in relation to particularly large FFDs. Have you got any advice for surgeons who are perhaps new to using robotics, how they might manage that so the information the robot gives them accurately reflects the soft tissue envelope?
Actually, this is different because we used also not the 2.0 system. We still use the 1.0. So in this circumstance, we usually do less distal femoral cut first. Then we do the release. Then after that, we can do the recut. So this is our technique.
Well, I guess flowing on from that then, using 1.0, as a rough estimate, what proportion of patients would you have to go back or make a decision to go back and do a secondary recut based on that posterior contracture or those FFDs that you see?
So actually, this is not very often. We do in our patients, we do not have a lot of very severe flexion contracture, about less than 5%, I think.
Thank you.
Thank you.
Did you have any other questions, Henry, for these gentlemen?
Yeah, can I ask Dr. Yan a question about sometimes we do have some large posteromedial osteophytes over the femur. I see that you say that sometimes you do provisional cut to take the osteophyte out, but sometimes I do find that it's rather difficult for me to perform. Is there any other way, for example, do you have a prediction of how much that osteophyte would affect your flexion gap over the medial side or extension gap over the medial side, so that you can probably still do a pre-resection balancing and decide, or do you try to make the figures 1919 all the way before you do the surgery and take out the osteophyte before you do the resection? Thank you.
Right. Yeah. So I seldom actually do a provisional cut of the posterofemoral condyle just to get the posteromedial large osteophyte. Based on my experience, I would say I seldom encounter a case that will give you like more than 1 or 2 millimeters of laxity after you take out the posteromedial osteophyte. So I think the effect is not so large. So if you see a huge posteromedial osteophyte, maybe you can estimate that after removing this part, that will give you 1 millimeter laxity on the flexion gap of the medial side. So when you do your pre-resection plan, you can take that into account, and maybe you cut 1 millimeter less on the medial flexion gap, and anticipate the gap will open up a little bit after you take out the osteophyte. I think it's based on experience. You try a few cases like that, and you know the rough estimation how much laxity you can get after taking out the osteophyte. I actually have a question for Professor Chen. I think there's something very interesting that not too many robotic surgeons mentioned, but I heard this concept during the Asia meeting in Shenzhen last month. So I think one of the French surgeons emphasized on the patellofemoral component. He said that we have to actually match our component according to the geometry of the trochlea. But sometimes it's difficult. When we try to balance the flexion gap, sometimes you can achieve very good flexion gap balance. But when you look at the component, you always need to put a few degrees more external rotation. So actually, the component is not matching the shape of the trochlea. So which one do you think has the priority? Whether you want to match the trochlea or whether you want to get more balanced flexion gap, which one will give you a better outcome?
That's a good question. I also noticed that in our practice, I just do the same thing like you. We balance the gap first. The trochlea is I think he mentioned the trochlea position is medial or lateral. This is very important, not the angle or the rotation of the femur.
Okay.
Okay, so I think we had quite a good discussion, and since time is running short, so let's just move on to the third part of the seminar, and to ask Professor Kermis on his perspective and his experience. Professor Andrew Kermis is a specialist orthopedic surgeon and clinical associate professor at both the University of Adelaide and Flinders University. He is leading a special issue in arthroplasty with the topic of advances in artificial intelligence and robotics in joint arthroplasty. Professor Kermis has a special interest in primary and revision, hip and knee replacement, complex primary arthroplasty, and both computer-navigated and robotic-assisted surgery. Let's welcome Professor Kermis to give us his presentation on managing major bone loss in primary total knee arthroplasty, robotics making complex arthroplasty better. Thank you, Professor Kermis.
All right. Well, thank you, Dr. Fu. I appreciate that. So I thought in covering the topic today of major bone loss, I thought I'd use what is a fairly simple case example as an opportunity to highlight some of the challenges in primary arthroplasty with managing significant bone loss. So this is moving into the complex primary demographic. And I'll use a real life case example, one of my patients that I saw early on in the piece. So I thought, again, being a real-life example, I hope the audience can learn from some of the mistakes and errors I made in my journey. Some of the things certainly now with hindsight I would do differently. I think it's important to keep in mind that the case I'm going to present was actually quite early in our journey with transitioning from using robotics for primary arthroplasty into complex primary and then revision surgeries we might do now. And it's a complex case which gives us a little bit to think and talk about, not just from the operative considerations, but very importantly for the patient considerations as well. And as I mentioned, robotics for us early in the process. Again, some of the audience will know I am a passionate believer in both artificial intelligence and robotic-assisted surgery. And a little bit of what I'll talk about today, I've touched on a couple of our recent presentations and publications in arthroplasty. So this is a normal Tuesday morning for me. I get a phone call from the major trauma centre nearby. In fact, a good friend and colleague of mine who is an orthopaedic trauma surgeon rings me and says, Andrew, I've got this young man. I would appreciate you meeting him and having a look, see what you think. Our patient is at the time a 37-year-old male. He's an office-based worker. He works in information technology, works with computers. But away from that, he's a healthcare worker. He's a volunteer ambulance officer, gives his time to the community to help others. Now, the events leading to his circumstances, this gentleman is working on his car at home in his driveway. He's changing brake pads, doing something. Unfortunately, for some reason, the chock on the car loosens. The car starts to roll down an incline. So he pops himself up and starts to run after the car. After a few steps, he describes a significant audible crack. He's not struck by anything per se. He doesn't fall per se. This is mid-stride, collapses to the floor in significant pain, and he's unable to bear weight. So he's transferred, ironically, via ambulance to the local tertiary trauma centre and is very quickly and appropriately diagnosed with a significant Schatzker 6. There is a major coronal split, as you can see on that lateral view, and a huge amount of comminution. So a challenging looking case. So our the CT scan that was done at the time, it's quite quick, but it really does highlight that bone loss posteriorly. So quite a deficit to play with. And the 3T highlights he's got splits in all sorts of directions. So, it's certainly not an insignificant injury for this poor young patient. And that's certainly the sort of thing that makes us all sad. So the trauma surgeons do what they are incredibly good at, and they work very, very hard over a 2-stage operative plan to put this gentleman back together. And look, there's almost more metal than bone there. Okay, there are multiple plates, multiple incisions, lots of screws. Unfortunately, as time settles, they haven't got his mechanical balance right. And that's pretty obvious why. You can see that significant residual defect and disruption in the lateral compartment. And that's really not a joint surface that's going to be compatible with functional weight bearing moving forward. So he needs something done about that. So this gentleman's a tricky patient. He's got lots to think about. He is young. At the time of this injury and at the time that I see him a year later, he is under the age of 40. He is a healthcare worker. He's a man who gives his time as a volunteer to help the community. He is in significant pain. He's almost at a stage where even with supported devices, he's not bearing weight on that limb because it is hurting him. And at this stage, he's had multiple surgeries. He's had 3 or 4 operations before I meet him. And I guess what was alarming from my perspective was that he had already been offered a fusion of that knee or a through-knee amputation, which I can understand didn't appeal to him, but certainly seemed a little bit aggressive from where I was sitting. And I guess what broke my heart, to the point of referral, he's not been considered for any form of primary or secondary arthroplasty, despite his clear functional issues. So, that was something that had me very concerned. So we organised to have that extensive metalwork removed. That's not a small process. And to be fair to the trauma service, recognising the injury that this gentleman had originally, they've probably done a wonderful job restoring on-block bone stock, but very, very clearly he still has issues in that lateral compartment. So we need to have a think, what can we do for this gentleman? What can we offer for him? Now, very genuinely, I believe in any complex case, one of the absolute key features is an effective plan, and it needs to be a plan that has contingencies both for expected and unexpected eventuations in the operating theatre. So revisiting what's important for this specific patient, he's had major soft tissue injury, both as part of his original trauma And also his multiple surgeries. He's got multiple extensile incisions around the knee, and we've asked a lot of his tissues in the healing process. Now, including the removal of metalwork, he's had 5 operations before we get to him, and that's a concern for all sorts of reasons. There's scarring, tissue viability, blood flow, and the infection risk, of course, is cumulative with every new operation he's had. So we need to factor all that into mind. Dealing with that lateral side, well, as an arthroplasty surgeon, we start to think, how are we going to reconstitute a joint line for him? Are we going to do that with bone grafting? Are we going to use simple unilateral augments? Are we going to replace sections of bone on block? Respecting that even though there is bone in that metaphyseal region, it's bone that has been heavily fractured, high energy trauma, has been repaired, had instrumentation of metalwork and had that metalwork removed. So the quality of the bone block is not necessarily fantastic either. The final 2 things I think are really, really important, and it's balancing both the expectations of the patient. This is a young man. He is a worker. He is a father. He is a husband. He is a volunteer. He really wants to be back being active and moving again. And the other consideration is our own local limitations and capacity. What can we deliver for this patient? What will our resources allow us to do? What can we offer this young man? So again, just revisiting where we're at. So it doesn't look great from an AP perspective. When you have a quick look at the notch view, which comes up next, you really start to appreciate what a deficit he's got, particularly running off posterolaterally. And it becomes very, very clear on that view alone why this is not an injury that is compatible with sustained long-term independent ambulation. So he's got problems there. So the next step for this fellow, he was presented by the original trauma team to the local complex arthroplasty consensus meeting, and a series of ladies and gentlemen, young and senior surgeons together gave opinions on how best to manage this person. And I guess what was horrific now, looking backwards, given that this conversation was 2 or 3 years ago now, almost universally the recommendation was for a primary hinge for this knee. And in my mind, having listened to that discussion, the only real consideration was whether that was a hinge with a unilateral augment or whether it involved some medial and lateral replacement and bring the joint line up to start with. And again, it seemed very excessive to me for a young man. He's got a lot of life ahead of him. So for us, at a stage when robotics were well established in primary surgery, it was an opportunity to look and see, could we capitalise on the precision of the robotic assisted cutting and the information about the soft tissue envelope to help us avoid having to be quite so aggressive and sacrificing in our original operation. So we had to think about it and then decided, well, perhaps at the time our ROSA robot may have been a good opportunity to test the capacity of this system. So we decided, based on several reasons, with 4 different robotic systems available locally, we decided this might be a good case for the current generation of the ROSA. So simple process. It had enough CTs and bits and pieces as it was. It is a biplanar plain film imaging process converted to a 3-dimensional topical rendition, and we use those to plan our surgery. And as I mentioned before, I really genuinely think that the effort in these procedures in trying to give a person a good outcome comes from the pre-planning. It comes from the consideration long before you get to surgery. So we upload these systems, these images. They go off to New Jersey. They come back to us 3-dimensionalized, and we give them to the robot, and we have a think and a pre-plan together, very similar to the other speakers this morning with their Mako systems, an opportunity to interact with that plan. Now, set to default, the robot said, this is easy done. He's got a collateral ligament on that side. The lateral collateral doesn't insert onto the tibial plateau, it inserts onto the fibular head. So as long as we can reconstitute the alignment and build up volume, we will get alignment. But the default setting said take 1 centimetre or more off his good side, his medial side. And in a gentleman who's only 38 or 39 at the time, it seemed an excessively bone sacrificing approach for a young man. So again, the planning phase is an opportunity for us to set our goals. What do we hope to achieve for this patient moving forward? First intent is to try and preserve as much of the native bone stock as possible. Now, respecting the fact that some of that bone is not good quality bone, it's been injured and it's been repaired and it's had metalwork instrumented and removed from it. But the goal of maintaining minimalist bony resection, I think, was very important. We needed clearly, particularly with that deficiency, to restore his coronal alignment, to give him stability. And if that affected the overall limb, I think we had a bit of scope. I think our two speakers this morning already have highlighted that absolute mechanical alignment need not be the goal necessarily to deliver excellent outcomes for the patient. What's important for me is that what we're going to put in that person's leg, we need contact between implants and good bone, not just contact with bone. And I think that's really important. So understanding where the areas of deficit were around his previously injured joints and where we could make sure we had implanted those components with good bone stock around them. He's already had 5 operations. We need to be cognizant that his infection risk is not insignificant, and we need to take reasonable steps to minimise that. So we're thinking about his vascular tomes, we're thinking about his previous incisions, we're thinking about the amount of dissection and resection, and we're thinking about the size of the incision that we use to do this through. And I guess importantly for me, coming back to the future for this young man, is a guy who's under 40. He's, being average in this town, he's got another 45 years on him. We know if he lives to be average, he's going to need repeat surgery in the future. And we don't want to burn any bridges or disadvantage this gentleman by making bad decisions at this early stage. And on top of that, of course, he's an active young man and he wants to try and be that way if at all possible. So we're balancing what can we achieve versus what does he expect. Unsurprisingly, that operating theatre looked like an orthopaedic storeroom when we rolled in. We had equipment and options there to be able to deliver just about everything from a tibial replacing long-stemmed hinge through to primary implants with simple augments. So we made sure we had all the contingencies there, I think, in our learning phase. If I did that procedure now, 2 or 3 years later, I would be much more conservative in what I took in. I would have much more confidence in our ability to use the robotic system to deliver a good outcome. So just having a quick look at this young man's leg before we go, a huge deficit. Now, unfortunately, there's no sound to go with this, but the audible clunk as the lateral femoral condyle engaged with that tibial deficit was almost deafening. So now he's here. Let's get him ready. We've got to execute this plan. So we wheel in our prepared robot. And again, this is an early episode for us in our evolution from primary joints to complex primary or revision. So there's a little bit of trepidation around the process. It won't surprise you one little bit. This is a similar screen to some of the Mako ones, just a different presentation format for the ROSA. And it highlights that is a strongly valgus knee, unsurprisingly. It gets increasingly loose and unstable at 90 degrees of flexion, which highlights what we knew from the original imaging, that his deficit was not just lateral, but dominantly posterolateral as we went. So we've got to be cognizant of that as we move forward. Same as the Mako screens that went up before, a lot of manipulation has happened now in the theatre. And I think this is where the value is, in the theatre itself with the live soft tissue envelope, to give us information about balance that you can't really judge from the static imaging prior to surgery. So this is another case where I haven't spent a lot of time prior to surgery trying to manipulate gaps and numbers and cut levels. We've deliberately waited till we're in the theatre so we can incorporate what we know about the bones, what we know about the implants and the soft tissue envelope. And very deliberately, and this was pushing my envelope, I don't like skim cuts anywhere in primary joints. And 1 millimetre was certainly right on the cusp for me of something that I was uncomfortable with. But we decided, as was raised by a couple of our speakers before, we take a minimalist cut off that defective lateral side with a view that if we were uncomfortable or unhappy, we could very simply use the robotic technology to come back and recut as necessary to meet our comfort. So ultimately, that was the plan before we start our bony cuts. We've started with a sloppy traumatic valgus. We'll aim for mechanical neutrality, knowing that I would accept 2 or 3 degrees in either direction if we had a well-balanced safe knee. And if you remember from his pre-op imaging, he did have a gentle valgus attitude to that other side. So I think we had a little bit of scope for safety. So now this is where the orthopedics happens. All right, a little bit of work with the hammer in between. That may not be us in theatre. So there's the Mako. There's us at the end of the case. We're at the stage here now. The final implants are in. We've got the final poly. So a good straight knee that coronally, I can't show the dynamic video there, but coronally is now stable and good gentle flexion. He's well above 130 degrees, which was far more than we had expected. So certainly from our point of view, although that surgeon, he looks tired to me, but, I'm very happy with this result, but it almost doesn't matter what I think. It's about this patient. So let's see what we're able to give him. So that's what he ends up with. All right. So we end up that is the Persona system. We've gone with intermediate length stems, didn't need to go ridiculously long based on the bone stock. I have used for the observant onlooker, we've used a slightly thicker poly than I would like for a primary implant in general. And as a concession with a minimalist distal femoral cut, perhaps the joint line is up a couple of mils from native, but an outcome that we were very happy with radiographically. And then in the short term afterwards, this is him on day 3. So certainly he's still favouring the good leg, and he spent a year trying to do that. But to see him walking on a single crutch prior to leaving the hospital within 2 or 3 days was just remarkable and heartwarming. And I can tell you that young man has gone on to do well. We've got him at 2-year follow-up now. So at that stage, I think we'd say the robot's done a good job, and I've certainly learned to be more comfortable accepting the robot's input, which comes with experience and time, and we've gone on to do some good things together. So thank you very much.
Thank you, Professor Kermis, for the excellent talk.
Now, we'll keep going straight into the next talk. So Dr. Fu himself is going to speak to us now to give us the final talk in today's seminar series. Dr. Fu is the Deputy Chief of the Division of Joint Replacement Surgery at the Queen Mary Hospital in Hong Kong, so an enormous facility. He is also the Honorary Secretary of the Hong Kong Orthopaedic Association, so we're privileged to have him with us this morning. Today, he will share his experiences and expertise in managing something that is a problem, certainly in my practice, the stiff knee for arthroplasty using robotic technologies. Dr. Fu, please.
Thank you, Professor Kermis, and thank you all of the participants coming to join our symposium today. So today I will talk about managing the stiff knee with robotic total knee arthroplasty. So these are my disclosures. So in Hong Kong, we started to use the Mako robot in January 2019, and we did the first cementless total knee arthroplasty at the University of Hong Kong that year. And since then, we've been doing robotic assisted total knee, total hip, and partial knee arthroplasty. Why do we do robotic assisted total knee arthroplasty is because using the robot, we can make precise bone cuts, which aids us to have cementless fixation. There is better planning, enhanced planning with the CT based planning. We can maximize the host bone contact for cementless fixation. We can also perform dynamic joint balancing, like Dr. Yan mentioned in his talk, with gap balancing and less soft tissue dissections. With the haptic guidance, there is protection of the soft tissues, less chance of injuring the blood vessels at the back, and it is a useful tool for surgeons to help our patients. In Hong Kong, at our University of Hong Kong, we've performed over 900 robotic surgeries using the Mako robot. Of over half of them, over 500 cases were total knee arthroplasty. And half of them were done in Queen Mary Hospital, and around half of them were performed at Duchess of Kent Joint Replacement Center, where I also operate from time to time. And most of the implants we use are cruciate retaining cementless implants. We have presented our findings on the learning curve. Basically, after a certain number of cases, we can now achieve a learning operative time skin to skin of less than 1 hour. And compared to other conventional instruments and navigated cemented total knee arthroplasty, I think we are able to achieve time neutral. And in Hong Kong, we can see that there is increasing usage of robotic assisted total joint arthroplasty. And all the robotic systems in Hong Kong is also on the increase. This year, I think in total, we have around 13 robots, including Mako, Cori, Rosa, and later Velis this year. So how about managing complex primary knees like stiff knees? I have two cases to show today. First patient is a 40-year-old male patient with tuberculosis of the knee 1 year ago. Because this patient had a delay in diagnosis at a different hospital, the patient's knee progressed quite rapidly and underwent anti-TB treatment for the last 18 months. And you can see right now the patient has around 60 degrees of fixed flexion contracture. Also, the flexion range is limited to less than 10 degrees, the flexion arc. And to complicate the picture, previously the patient had a sinus tract from the tuberculosis, both over the medial side as well as the back of the knee joint. And this was his X-ray before we had the operation. You can vaguely see two cystic lesions over the tibial side with significant bone loss as well. The knee is kept in significant flexion, therefore the appearance on the AP view. And we did have an MRI which showed that there are some bone defects predominantly over the tibial side as well. So we were thinking how we can actually help this patient, whether or not robotic assistance can help this patient achieve a better outcome. And also what type of prosthesis we were to use. The patient is 40 years old. We do want some degree of stability as well as consideration for longevity. So we planned this patient for posterior stabilized and considered whether or not we need to use constrained implant intraoperatively. This was the pre-plan for the patient. So pretty standard bone cuts, and the planning was done using measured resection planning. You see, for the femoral side, we aim for a mechanical alignment, varus 0 degrees, and the bone cut over the femoral side is 8 millimeters, which is pretty standard. For the tibial side, I think we deepened the cut a little bit, and we also choose to use a thicker polyethylene in his scenario in order to have better longevity as well. And again, we planned for mechanical alignment in the first instance. Rotation-wise, we plan parallel to the transepicondral axis. Flexion is pretty standard, and slope according to the triathlon PS design is 0 degrees. You can also see in these pre-plans that there are some cystic lesions over the tibial side, which are quite sizable. And preoperative workup showed that the patient had normal ESR and CRP, and since the patient had completed a long course of anti-tuberculosis treatment, we were not too afraid that there was going to be residual infection. However, we did want it to be a bit more cautious, so we opted for a cemented component for this patient to add in antibiotics. Despite the extensive adhesiolysis intraoperatively, when we did the registration, we were not able to make the knee straight. And this was the intraoperative range we got from the patient: 57 degrees of flexion during extension and 73 degrees of flexion during attempted flexion. And the limb was at 6 degrees of varus. And you can see that with this, we are not able to assess the flexion laxity as well as the extension laxity over the medial and lateral side. So how did we go about to manage this patient? We still had to perform a preliminary tibial bone cut, and then we did more soft tissue release and go for a mid-resection balancing instead of the usual pre-resection balancing with the robotic technique. In the end, what we did is we did have to proximalize the joint line quite a bit, taking off a bit more over the distal femur. 15 millimeters is how much we took off over the distal femur, and we were finally able to achieve the limb of 5 degrees of residual flexion contracture. You can see that the femoral component is proximally migrated quite a bit. We were able to put the limb in around 3 degrees of valgus, probably the medial side and the lateral side. Balancing was also difficult with some opening up of both sides. And for the flexion, I think it was all right for this patient. And comparing the pre-plan, you can see that we moved the joint line proximally quite a bit to achieve this balance. And this was the patient post-operative. We did cemented implant tibial side. We put in a stem. In the end, we still chose to use a varus valgus constraint type of implant to produce more stability for this patient. And this was the long film after the operation. The patient alignment is in slight valgus, but the patient is quite happy. Initially, there was previous sinus tract, and after the operation, we did worry that this might become blister and cause problem once it ruptures. But luckily, with negative pressure dressing and daily dressing, it still resolved on its own. And the patient's range at 2 weeks, you can see that there is still some fixed flexion contracture and of around 5 degrees, but quite a bit of extension lag. And the flexion range was around 70 degrees at that time. But luckily at that time, the wound has completely healed. So for this patient, since he is only 40 years old, we decided to go for MUA for this patient. And intraoperatively, we can achieve flexion of 110 degrees and almost full extension. At 1 year post-op, you can see the range of motion is preserved for this patient, alignment is well, and the previous sinus tracts have completely healed. X-ray is looking good now. The advantages of robotic total knee for stiff knees is accurate planning in terms of implant size. You can also visualize the osteophytes or any bone defects. For this example, I think the most important use of the robotic is allow us to do multiple recuts. Initially, we planned for 9mm cut over the distal femur, but in the end, we ended up cutting 15. So we moved up using conventional jig. You might need to move it 3 times and put in extra pins. But with robotic, it can maintain the accuracy even with multiple bone cuts, unlike the jig-based conventional. And assessment of ligament balance and help us decide to use a constraint implant and assess the alignment. However, there are some disadvantages. Software is not compatible with the constraint or stem implants yet. Hopefully in the future, they will improve. Registration is quite difficult and it requires a lot of clearance of the scarring. Luckily, this is CT based, so we can just rely on the anterior reference points to complete the registration, and pre-resection balancing is not always possible. A preliminary bone cut with conventional saw may be necessary, and ligament balancing is difficult. And there are some review articles talking about the stiff knee. This article published in India shows that there is average arc of motion for stiff knees of 75 degrees. And there's also another paper talking about the improvement in range of motion for a complete ankylosis and a partial ankylosis, but we know that there is significant complication in these patients. The second patient is a patient that is not so fortunate, 68-year-old old age home resident with schizophrenia. She's been wheelchair bound for the last 3 years, and flexion contracture of 50 degrees. And the flexion range was still okay to around 100 degrees, but significant fixed flexion contracture. We plan for a one-stage bilateral total knee replacement for this patient intraoperative manipulation showed flexion contracture of still around 50 degrees. So we did one side first and then the other side, planned for a triathlon, cruciate retaining, cemented total knee arthroplasty, because we expect a lot of distal femoral bone cut. And with the triathlon in a small lady with a large box, we worry about the risk of fracture. That's why we chose for a cruciate retaining implant. And for this patient, we had difficulty for pre-resection balancing. Again, we need to do a preliminary bone cut, and the left side was completed and proceeded to the right side. But the right side was not so lucky. When we did the surgery, we did a preliminary tibial bone cut and thickened the tibial cut by 2 millimeter and did the bone cut at 90 degrees without the knee subluxation. And after that, we used a chisel to remove the tibial bone piece. And subsequently, upon knee extension, we found that there's arterial bleeding and hemostasis was unsuccessful from the anterior. The vascular surgeons were consulted intraoperatively. This was the bone cut we achieved intraoperatively. And we can see that actually there was a laceration of one of the popliteal arteries, around 50%, not a complete laceration. Popliteal artery and vein were injured. And at that time, we completed the bone cuts from the front, temporarily closed and redraped in prone position, repaired the artery and vessel by a vascular surgeon, closed the wound posteriorly, flipped the patient back supine and put in the implant from the front. And this was how the patient appeared after the operation. And luckily for this patient, the circulation remained good. The nerves were all intact and the patient wounds healed without problems. The patient could finally walk with a frame with a few steps. But due to the previous nature of the patient with psychiatric illness and old age home without physical therapy, a lot of the flexion contracture did come back for this patient. So the surgical difficulties for a stiff knee are exposure, adhesions all around. You can consider implant choice. We do know that posterior stabilized implant gives you a better flexion range, but for certain implants with the box being quite big, you do risk a chance of supracondylar fracture if you do proximalize the joint line quite a bit. And proximity of the neurovascular bundle during extension, especially in patients with significant FFD, once you extend the knee, the vessels come into close proximity. Standard exposure with medial parapatellar approach can be used for these patients with more proximal wound extension, more lateral retinacular release, and external rotation of the tibia so that you can get to the back of the tibia and do more posterior soft tissue release. Some have advocated extensile exposure like rectus nip VY or even transepicondylar osteotomy. And you can sometimes do an initial resection and subsequent resection in flexion. And another study reported that the most important determinant of postoperative range of motion was pre-op range of motion, and VY quadriceps plasty had inferior results. Another study published in the Journal of Arthroplasty talking about whether or not the knees were better in if they were stiff in extension versus those stiff in flexion. Again, they use different types of implants, including cruciate retaining and posterior stabilized, and they found that those who were stiff in extension usually had poor flexion range, but better extension range. But they do report significant complications, up to 20% of complications, mostly in terms of residual stiffness or flexion contracture. Finally, I want to say robotic arm-assisted total knee for stiff knee is able to give you an accurate recut, and we can navigate the soft tissue balancing and alignment, but the surgical difficulties and risk of the complications still hold true. And it is still a useful tool for the surgeons to help their patients, but still the surgeon has to pay attention during the surgery. Thank you very much.
Thank you, Dr. Fu. Another fantastic talk, and I love the fact that you would help us all learn by sharing some of the challenges and complications you've had. So certainly, I guess it highlights for the audience that the idea of haptic boundaries with regards to robotics does not mean that you are absolved from surgical decision making and the risk of complications. Those heavily fixed flexion contractured knees, those stiff knees, are a real challenge for everyone. And as you've shown, I think the sensible application of robotics has been a huge advancement, but it certainly doesn't take the place of excellent clinical judgment as well, which obviously you've done. They are a real challenge. So having concluded the four main presentations, I think we'll now reconvene our panel and take some questions perhaps from each other or from the audience. I did see a few things coming through as well on the talks. Gentlemen, did you have some questions to start us off?
Dr. Fu, I have a question for you. Can I have a question?
Yeah, sure.
I noticed that in your two cases, you both of the two cases, you deepened the tibial cut. Well, what's the reason?
Yeah, I think for both cases, we had difficulty achieving full extension. So I know that I can achieve that by elevating the femoral cut, but I just didn't want to elevate it too much because we did have some experience, especially when we used posterior stabilized implants. We deepened the femoral cut by too much, and fractures do occur. Supracondylar fractures of the femur do occur. So that's why I just want to share out the deepen cut for these cases. So for the tibial side, I deepen the cut a little bit for both cases. Having said that, I do know that deepening the tibial cut would sometimes also affect the flexion gap, make the flexion gap a bit loose, and sometimes also cause some challenges in balancing. And in some cases, we also need to deepen the cut if we see that there is some bone defects. We want the prosthesis to have good bone contact. Some cases we do deepen the cut a little bit, but usually not to a very large extent, I would say.
Thank you.
Thank you.
Can I ask a question to Dr. Kermis? So I'd like to know in your practice, how often do you use the robotic assisted surgery in doing knee replacement? And I understand you probably have access to multiple robots, like the Rosa you said, probably you have access to Mako or Valus. So how do you decide actually which robot to use? For example, for your case you presented with the post-traumatic osteoarthritis, you finally chose Rosa. Can you give us your thoughts and rationale in choosing this Rosa over other robotic systems?
Yeah, fantastic question. Thank you. We are very privileged in my local setting that we have access to 4 or 5 different robotic types. The Valus is here. We have multiple Makos available, multiple Rosas. Navio is used quite extensively as well. So we're almost spoiled for choice. To a point, I guess one of the deciding factors on which technology to support for a particular patient has been driven by the implant system that it's aligned with. Yep. So again, as you gentlemen will know with your Mako descriptions, and until they add the extension to TS and VVC and hinge, there's a limit to the triathlon. So if you were comfortable that the triathlon series would meet the needs for your complex patient, then it's an excellent robot. In fact, that was the robot at the original hospital that this patient presented to under the trauma service. So that was certainly considered. One of my feelings with the Rosa, again, it is aligned with a particular implant series at the moment, is that there were slightly more options that we could use the robot for. And indeed, part of what I had the privilege of being involved with early in Australia and New Zealand was some of the extensions from primary CRPS knees to VVCs and indeed hinges. So to have a system that gave us compatibility, that was important for him. That case itself was nearly 3 years ago now. So again, it was early. We were still developing confidence in what the limits of the system were. And as all three of you have presented this morning, robotics can add a huge amount to your patient care and the outcomes you deliver, but it's not perfect. And it works best with good clinical decision-making, good surgical decision-making in the background. So I picked Rosa for that particular case because I was hedging my bets that if we ended up with a constrained implant or a hinge, that I wanted a system that made that safe and compatible for him. In hindsight, I probably could have got away with a PS or a PS with a stem maybe to bypass the defect. But I certainly early on didn't have that confidence. Now I think, 2 or 3 years later, I'd make much clearer decisions. A lot of it, of course, as you all know, is not just access, but is surgeon comfort. There is a learning curve, as the audience knows, with all of the robots, all of the technologies. I think if you've done many hundreds of Makos, as you gentlemen, your facilities have, you can understand there is an advantage to staying with a system with which you are comfortable. And I think I'd make that general recommendation to surgeons in general. I think the very complex case is not the time to be toying with something that you don't have experience with. I think when you've got the most complex cases, I think you go back to what you are most comfortable with, what you have the most experience with. I think that combination of very challenging, complex pathology and technology or systems that you're not familiar with, I think that can be a dangerous pairing. So I think to a point you play to your strengths.
All right. I have a follow-up question to Professor Clemens and also Professor Chen, because I think I noticed from Henry's talk, I think one of the reasons that you caused the vascular injuries probably because you didn't sublux the tibia when you tried to cut it. So you couldn't see the posterior side of the tibia. As a result, the saw may went too far. So I want to know from the other two speakers whether you sublux the tibia when you do Mako surgery. Do you sublux the tibia so you can actually see the whole tibia before you cut the bone?
Do you want to go first, Henry?
Yes. Actually, I don't sublux the tibia when I use the Mako. I don't. Okay. It is not necessary to see the back because we don't have so complex knees, especially for the flexion contracture or extension contracture, stiff knees.
Okay.
I think, to be fair to Dr. Fu and the team, I think that particular case, stiff knees are some of the more challenging ones I deal with. I think they're really, really hard, particularly those large FFDs that are 40-odd degrees plus. I think in the context of recent aggressive tuberculosis, I imagine that the soft tissue envelope at the back of the tibia, not just the back of the femur, is horribly scarred and adherent. I got the sense, Dr. Fu, in retrospect, was it the chisel that got the vessel though, or was it the Mako?
Yeah, I think we don't have the definite answer, but they were both considered. I did use an extended boundary for the Mako to do the tibial cut, but nowadays, since that case, I've changed my practice. So for the tibial cut, I always do not extend the boundaries. I also prefer to use the CR cut for a CR knee that actually protects the bone island in the middle. And just in general being more cautious. But again, for the standard knees, I do not sublux the tibia anteriorly. I just put retractors over medial and lateral aspects and protect the MCL and LCL when I make the bone cuts.
How about you, Dr. Yan? You sublux?
Well, yeah, I sublux for soft tissue release and approach, but when I cut the tibia, I do not sublux the tibia as well.
Okay. I have a question for both for all of you. If there is a stiff knee, I don't have any experience for the stiff knee. If it is the extended stiff knee, is there any tricks to do the registration when we use the robot. Because when we do the registration, if it is extended stiff, you cannot register the posterior, the notch. How about any tricks?
So for the case I did with the TB knee, it's not completely extended, I have to say. It's mostly flexed, but I could not access the posterior aspect, so I still registered all the points over the anterior aspect. Since it is a CT based, I just try to register the landmarks that are more prominent, more atypical, rather than registering over a flat surface. But I have not had any experience managing patients with bony ankylosis or even in complete extension fusion. So I do expect that those cases might be a bit more difficult for the registration. However, since it is CT based, I would think that they might be able to get a pass with multiple attempts.
Well, personally, I don't have any experience in using Mako in very stiff knee or ankylosed knee, but I think sometimes if you find a knee it's very stiff or has very limited flexion, if it's not fully ankylosed, or after your surgical approach, you sublux the tibia, usually the knee can be bent further. So I don't think in those cases registration would be a big problem. Like Henry said, I think it's CT based. I would try to register my points as dispersed as possible to cover all the visible area or accessible area, and I think it should be quite accurate.
Yeah, I think using different systems, not just Mako, but across the board, similar to my question of the two of you early on, I think the soft tissue envelope information I try and give the robot intraoperatively once I've released a lot of we focus on bony issues, bones at the back of the tibia causing trouble. In the case of a stiff knee that is soft tissue bound, I think as Dr. Yan has said, I think a diligent approach and sequential soft tissue releases, those knees almost universally for me, despite Dr. Fu's expertise, are a PS style implant. So I would be releasing the cruciate ligaments early. I'd be gently subluxing progressively the tibia forward and trying to do as much of a synovectomy capsular release as I can, preserving the two collaterals. And again, look, it often, I think, is a compromise. It's rarely a 90-degree position for your point registration. But I think in most cases, with a diligent, sensible soft tissue debridement, not release, but debridement to get there, usually you can get most of the key points, accepting that sometimes it's a little bit of a compromise between ideal and what is realistic. But yeah, they are really challenging cases, stiff knees. They're some of the hardest to manage, I think. I had a question for all three of you as well, if you don't mind, gentlemen. It's a little bit of a bugbear of mine when I'm teaching robotics to others. I think most of us, certainly in my setting, when we start learning a new robotic system, there's a lot of time devoted to the preoperative planning phase, so manipulating the software well before coming to theatre, sitting in your office type things. And you can spend an enormous amount of time planning cuts and releases and implant positions before getting there. I think one of the things that I've changed over time, I tend to do that less and less and less now, other than to prove generally I can get the basic fundamentals in. Like Dr. Fu said, maybe making sure that the bone size is big enough to accommodate a box cut or whatever we need, or implants. But I do most of my soft tissue envelope and planning in the theatre with dynamic information. Can I ask the three of you, how much time do you spend on your routine robotic knees planning prior to surgery?
So for myself, I usually just plan during the when the patient goes into theater. So when they're putting in the anesthesia, I usually look at the plan maybe 5 minutes or so, because I think for total knee replacement, the planning may not be as important compared to total hip replacement using the Mako, where we also consider spinal pelvic balance. For the knee, I just want to make sure the sizing is okay, the rotation is okay, there's not significant bone defects or so. So in that sense, I've moved away from spending time in the office to do the pre-plans, unless I have a very special case like a stiff knee or defect case.
What about you, Dr. Chen?
Yeah, actually, in our hospital, MPS do the plan before, and we just use 2 or 3 minutes before the surgery with the MPS, and we adjust the rotation, adjust the size. It's very short time.
Dr.
Yes.
Yan?
Yeah, same for me. I think a trustworthy MPS is very important. For my own practice, actually, I don't see many complex primary total knee replacement a lot because I work in a private hospital. So most of my patients actually have straightforward osteoarthritis. So my MPS will do all the pre-op planning for me, and because they're very knowledgeable, they will actually send problematic cases, images to me if they encounter some difficulty. But otherwise, I just do the pre-op planning. When I go into the operation room, when the anesthetist, is doing the anesthesia, then I quickly go through the plan. And then, like Dr. Clemens said, I do most of my planning intraoperatively based on the dynamic knee balance information.
And I think all four of us have said similar things there. So for the audience's benefit, one of the criticisms of technologies, particularly robotics, when we talk about operative time, is the astute proponent will say, well, you may not be changing your physical operative time, but what about all this extra time that you spend planning and preparing and manipulating software? And my answer to that, and it sounds like what the three of you have said as well, is that there is no additional workflow change as far as my timing, because we're either doing that live in the theatre while making other decisions, or the planning, like you said, Dr. Yan, is happening while other parts of the operation, perhaps while the induction is happening and I'm sitting there in the theatre. So genuinely either time neutral or time saving if you apply the surgical time. Dr. Fu, if I might, another question for yourself specifically about your first case, that tuberculosis one. Again, that's an incredibly challenging and difficult case and looked like you achieved a remarkable outcome for that patient. Can I ask you specifically about those 2 cysts, though? You demonstrated on some of your pre-op imaging some very impressive intraosseous cysts, presumably related to the scarring from the tuberculous infection itself. I notice, other than bypassing with a stem, you don't appear to have curettaged them or grafted them or cemented them. You were obviously comfortable intraoperatively that they were a reasonable foundation for the implant?
Yeah, intraoperatively, we did take a look at those cysts, and actually we did curette a bit and then put in the bone graft pieces. So the pieces of bone cut, we grafted over the 2 large cyst areas, and then we put in a stem for that particular patient. On that note, actually, I have a question for Dr. Kermis as well, because both of our cases are relatively young patients. We chose we use a cemented stem for these patients. Can I ask your opinion, the comparison between using a cementless implant and using a stemmed cemented implant? Because I did have some consideration whether or not I would go cementless, thinking that this would probably be a more biological fixation. But the consideration at that time for my patient is due to those 2 cysts, and probably I did want to put in some antibiotics with the cemented stem. So just want to know your thought on this.
Yeah, look, again, fantastic questions. And it sounds like I have a very similar philosophy to yourself. As a general rule, for a complex primary patient with normal metaphyseal, diaphyseal bone stock, I do like the uncemented stems in a young patient. I think the biological fixation is a good one. There are a series of subgroups of patients that I would default to a cemented stem, and you've hit on a couple of them already. So if there is a concern about infection either through multiple procedures, so in my patient, our operation was number 6 on that gentleman in the setting of major trauma. So, I was concerned at 39 years old when I did that operation for him If he develops an infection, we've really dug him a big hole. We've done him a disservice. So same as you, I used an antibiotic impregnated cement throughout. I used the Copow revision cement for that purpose to try and, we can't eliminate his infection risk, but we can certainly try and, mitigate that as best we can, keep that risk low. The other group that I prefer cemented fixation, the other two groups, I guess, are if the bone stock or bone quality is poor. And in a post-traumatic setting, and I tried to highlight that in my talk, even though the trauma surgeons had done a fantastic job in reconstituting a block of bone in his tibia, that was not native healthy bone, even though the outline was there. This is bone that's been in multiple pieces, has healed, with various degrees of scarring and completeness. So in that particular setting, I have a preference to cement. It allows me a little bit of freedom to fill in any defects or compensate for abnormal bone. And I often curettage through my hole into the tibia for my stem or my keel quite aggressively to make sure that, bone that is of poor quality or is soft tissue scarring based is removed, so I can put cement against the solid void. I guess the third group where I think cement's very helpful in my practice is when there's significant joint line obliquity or concern about it. So if I'm using implants, particularly stemmed implants, to make an adjustment to bone, and it might be because I'm taking an oblique surface and making it parallel or vice versa, I think the cemented stems, cement from the joint surface through to the stem gives me a little bit of safe flexibility to make sure I can really position those implants where I would like them to do to make the correction I want, as opposed to being dictated by stem engagement along a diaphysis distally. And I can think of a couple of examples in my own hands where I have done that. I've gone to an uncemented stem and I've ended up accepting a slightly compromised joint line position where the implant has sat because I've been governed, even with offset stems, by stem engagement more proximally, more distally. So I think in my hands that would be how I would do it.
Thank you.
All right. Well, I think I haven't seen any more questions come through on the chat. One last time, were there any more questions from our three speakers of each other before we close up? No, everyone's happy. Thank you, men. So I guess, look, in closing, I'd like to make a couple of thank yous. I'd like to thank the Arthroplasty Society in Asia for their support and for providing the opportunity for us today, all four of us, to participate in this online seminar. And also would like to acknowledge and thank the parallel support and engagement of the Hong Kong Orthopaedic Association. Having Dr. Fu here is a privilege for all of us. I'd also like to acknowledge and thank the team in the background, the people you don't see, those behind the scenes that, of course, made the seminar possible. As a final plug, as I mentioned at the start, we are currently, for the journal Arthroplasty, preparing another special edition under the topic of artificial intelligence and robotic applications in joint replacement surgery. We have 4 international guest co-editors, Dr. Chen, who you've heard from today, Dr. Sebastian Lustig from France is a contributor, Dr. Francesco Zambianchi from Italy is involved, and of course myself. And really in this special issue, we're aiming to provide an opportunity for clinical researchers and arthroplasty surgeons internationally to contribute to the advancement of knowledge in the area of robot-assisted or AI-assisted arthroplasty. I'm very pleased to say, as of this morning, we already have accepted 4 publications to the edition, and they are excellent works. I would very much encourage all of you to read those. They're available via the website, and share that work with your colleagues. And equally, if there's anyone in the audience or on the panel who has work they feel is appropriate, we are very much inviting submissions for the edition and would certainly encourage that.
Okay, thank you, everyone. So this is the end of the second episode of the Asia Novo Seminar Season 4. Thank you all for participating and watching. Stay tuned and see you next time. Thank you.
Bye.
Bye-bye.